Welcome to Mind Your Mental Health channel, a channel for mental health awareness, psychological health and well-being. This is our 32nd episode. In this episode, we are going to talk about delusional disorders. As the name suggests, this is about delusions. It's a disorder primarily presenting with delusions. So the next question is, what is delusion? Delusion is an unshakable false belief. It's a very simple kind of explanation, unshakable false belief. But we need to add few more things. It is a fixed, unshakable false belief and inaccurate interpretation of a reality or bizarre belief not in keeping with the cultural or social or educational background of the person. So to put it very simply, it is an unshakable false belief, not in keeping with the patient's or person's educational, cultural or societal background. So there are three defining words here. One is fixed or unshakable. And the next one is false belief. So false belief is, you can understand very easily, the belief which is not real, the belief which is not true. And it is unshakable. That's where the kind of a real symptom comes in. I might have a false belief. If somebody comes and explains to me, I might say, okay, agree. What you told me is quite reasonable. I don't think what I thought was right. But when I have a delusion, I will say, no, what you are telling me is wrong. I know my belief is right. So that is the level of unshakable quality of the belief. So it is very, very unshakable. It's not possible to explain to them and clear the kind of the false belief they have. And sometimes it can also be inaccurate interpretation of reality. I might see something and interpret it wrongly. I might see two people talking at a distance. I might say those people are talking about me. They are trying to plan something to kill me. They are the people who are against me. They are the spies who are following me all the way. And they come into the house even when I'm not there, when the house is locked, they are always spying on me. They are stalking me. In reality, it may not be. But still, I believe that that is what's happening. Suppose my friend, my relative, my family says, no, it is not that way. Somebody is talking, you don't even know them. Why should they talk about you? There's somebody talking in the high street and they're talking about some of that issue. It is not about you. It can't be about you. But I would say, no, you are wrong. You don't know about the background. They are the people who are talking about me. They are talking very ill of me and they are trying to harm me. They are trying to plot against me. That is the delusion. That is the unshakable quality of the delusion. And because it's something which is happening, I am misinterpreting. So it is an inaccurate interpretation of what is happening. That is also delusion. Or I might have a completely the delusion which I think I am the king of this country. Then I will say I am the king and everybody should obey me. I might go and talk to my friend, my family and tell them that I am the king. They might tell me, no, you're the doctor, you're a psychiatrist. Then I would say, you're wrong. I was a psychiatrist, but now I have become the king. That is the belief, wrong belief, false belief I have. And it is unshakable. Nobody can convince me that is not right. So that is unshakable and that is the wrong belief. So when a person has a delusion, we usually say that they are not in touch with the reality. They are not in touch with the reality means what is happening around them. What actually is happening, they don't have touch. They think they are the king and they might behave like a king. So that is the definition of delusion. So delusional disorders will have predominantly delusion as a symptom. They might come to you with any type of delusion. So that brings in another question. What are the types of delusion? There are different types of delusion. I will I'll say few of the types. One is broadly we divide them into bizarre and non-bizarre. Non-bizarre is what you can understand. Suppose I say the two persons are at the distance talking about me. So there is some reality there. There are actually two persons talking, but I am misinterpreting. So it is not very bizarre. Bizarre delusion is something which you can't comprehend. It is completely bizarre. Now, I am a Star Wars and I travel on a cosmic race and I go to different planets and it will go on like that. So it will be very bizarre and you may not be able to understand. You can't fit in any of the real life situation. So bizarre and non-bizarre, broadly we divide them into two, bizarre and non-bizarre. And another more common type of delusion is persecutory delusion. Persecutory delusion is, we also call it as a paranoid delusion, where a person thinks or believes that people are trying to harm them. People are trying to persecute them. It can manifest in different ways. I might say, at my workplace, there are a couple of colleagues who always watch me. They always talk about me. Wherever I go, whichever department I go, they follow me all the way. But I turn around and say, I may not see them, but I know they are following me. So that is the persecutory delusion. Somebody is trying to persecute them. It can go to any level. It can ramify into many things. Now, I might say those two people had come home, planted cameras in my room. They watch me wherever I go. Even if I am at home, they watch me. And not only that, they also talk to other people and make them go against me. So it can elaborate. So persecuted delusion is one of the common delusions we see in our patients. Next is the referential delusion, where you have a reference. The example I quoted, two people are talking at a distance, they are talking about something, they are friends, and I don't know anything about them, they don't know me, but I believe they are talking about me. I strongly believe they are talking and they are plotting against me. And I might act on that. I might go and challenge them. Why are you talking about me? So that is a referential delusion. And there is another delusion called delusion of guilt. They may not have done anything wrong, but still they might have a feeling or believe that I have done something wrong, I am going to be punished. This is a negative kind of a delusion, more commonly seen in depressive disorders. So delusion of guilt. There is another delusion called nihilistic delusion. One expression in a nihilistic delusion is, I am dead and gone, I am not living, I am a dead person. Or they might say, my stomach is rotten and gone. I don't have a stomach. No, it's been rotting for the past 1 week and it's gone. So I don't have a stomach. That is nihilistic delusion. Then we have a delusion called grandiose delusion, where they have a extremely high level of self-esteem and they can feel they are the king or they are the prime minister of this country, or they might think they are the billionaire. And they own a couple of aircraft and 2 or 3 ships and have business all over the world. In reality, they may not. They'll be a very ordinary person working somewhere, but they'll think they are the millionaire and they behave that way. That is grandiose delusion. So everything, the belief system is completely grandiose, which is not in touch with the reality. Actually, in real life, they are not, but they'll have the belief, unshakable belief, that they are the most richest person in the world. Then there is another delusion called delusion of love. It has a different names also. In the past, we used to call it as erotomania. And this is mainly a delusion or unshakable false belief about somebody in love with them. So usually it is a person who is in a higher status than them. So very commonly in that kind of erotomania symptom, we see patient coming to us telling that some of the royalties are in love with them, they write to them regularly and they are in touch with them. That kind of a belief system they have. I know a patient who has a strong belief that she has married the king, the present king. That time I was a prince. So we try to treat them, give them medication. They might become all right, and we can discharge them. They might stop the medication. They relapse. They get back all the delusion. Every time we treat them and send them home, and then they get well, then they stop it, the person will have a relapse. And then the person will straight away go to James Palace and then go on to the gardens there and then make a big scene and say, I want to meet my husband who is a king or who is a prince, and invariably the system picks up and then she'll be brought back to our clinic. So this is one example. Now, erotomania or delusion of love. It is very, very unshakable. Or no amount of talking to them, no amount of reasoning will clear that delusion. Only the treatment and medication can clear it. And delusion of jealousy especially happens in the marital context or relationship context. We also used to call it as a conjugal paranoia or Othello syndrome. Now, famous Shakespearean character Othello, who doubted his wife. So this is mainly a doubt about the partner or person who were in the relationship. So main delusion is about infidelity. My wife is not faithful to me. My husband is not faithful to me. They are cheating on me. They might have this delusion contrary to the evidence which is existing. I'm not talking about real situation where the husband or wife having another affair or cheating on themselves. That is a different situation. I'm talking about where there is no evidence, there is nothing like that is happening. Still the person feels, the husband or wife or a partner feel they are not faithful to me and they are having infidelity and they go away. They do it without my knowledge. I know there are evidences. I look for evidence. There are evidences. All this could be imaginary. So delusion of love or delusion of jealousy is another delusion. And we also have a somatic delusion where they feel the body parts is distorted. Now I might feel that my nose is turned this way, and I will have a strong belief that nose is turned this way. And I would go to different surgeon, I go to ENT surgeon, different surgeon, ask him to correct the nose. Or I might say my face is deviated this way. Or they might have any kind of a false belief about their bodily parts. So that is called somatic delusions. And delusion of double is another interesting delusion where the person who is having the delusion believes that somebody near to them, a family member or a friend, are in doubles. I'll explain further. So I might have a friend who comes to me very often, we meet every week and talk. Suddenly I'll develop a belief that that person is not the real Mr. X. X is gone. Somebody in his form, in his appearance has taken that place. So whoever is visiting me is not a real X, Mr. X. This is somebody else. That person's double is trying to talk to me. There is ulterior motive why he is doing that. So there is delusion of double. And it is also, we used to call it as a Capgras syndrome. So these are different. There are many more types of delusion. These are all different types of, some of the common types are enumerated here. So now we know what are the symptoms of delusional disorder and what are the different types of delusions. Okay. Now let's go to the diagnosis. How do we make a diagnosis of delusional disorder? Because it is delusional disorder, we expect only the delusions. Usually, by and large, you will not have hallucination, other kind of a psychotic symptom. So it will be predominantly delusion. And so a set of related delusions might be there. And it should have lasted at least for 3 months. So we expect about 3 months of experience of this delusion to make a firm diagnosis that actually this is a delusional disorder. Because there is also a condition called acute psychotic or acute and transient psychotic episode. They might have symptoms for a couple of weeks and then completely it will clear. They become completely all right, 100%. And that is not delusional disorder. Next is if the delusion occurs in the context of other psychiatric disorder, suppose a depressive develops guilt, delusions of guilt, or nihilistic delusion, that is not delusional disorder because it is secondary to the mood disorder of depression. Similarly, a mania patient, in a bipolar patient, when mood goes high, we call it mania. In mania, patient develops very severe grandiose delusion. That we don't call it as a delusional disorder. That is part of bipolar disorder. And that's why it needs to be only delusion. Predominantly 90% is only delusion. No other symptoms suggestive of any other psychiatric disorder. So that is the way we diagnose delusional disorder. And it is sure the delusion system should also not be related to alcohol and drug use. Then it becomes secondary to alcohol. So these are some of the kind of factors we look into when we decide whether a patient suffers from a delusional disorder or not. Next question is, how common is disorder? Some of the studies have highlighted that 0.05 to 0.1% of the population may suffer from delusional disorder. Usual onset of age is around 40 years. Around 40. It can also happen earlier or later, but generally we see them around 40 years of age. And for many years, long period of time, they go unnoticed. Because I might have a suspicion, I might have a belief, I might not discuss it with everybody. I might keep it to myself. I might act on it, but I won't discuss it with anyone. I might feel that they may not believe me. So I keep it to myself, might act. Suppose I have a suspicion that my colleague is plotting against me, trying to harm me, trying to kill me. I can express it to my family or friend immediately, or I keep it to myself. But my behavior will change. Whenever that friend comes to me or colleague comes to me, I'll become hyper alert. I might feel anxious. I might avoid that person, go away from that room. So those kind of behavior might develop. Sometimes that behavior indicates that person is suffering from some kind of a psychological problem. So they go unnoticed for a long period of time. And among the delusions, persecutory and jealous type of delusions are more common. We see more of a persecutory delusion and more of a person coming to us with a delusion about their partner or the wife or any kind of a relationship. And the persecutory and jealous type of delusion is more common in men, and erotomania or delusional love is more common among women. It can occur in any sexes, but is more common in these groups. The next important question is, what are the causes? Why do they happen? Why should a person get delusional disorder? In psychiatry, we usually talk about biopsychosocial model. I've explained about this in previous episodes. What it means is we are looking at different causes, different reasons a person can develop a psychiatric illness. That is same for delusional disorder. Bio means bodily changes, bodily reason. Psycho means psychological. Social means sociological or societal reason. So what are the biological or bodily reason? All the psychiatric disorders do happen because of the changes in the neurotransmitters. There are chemicals in the brain which we call it as a neurotransmitters. They transmit data and information, and these chemicals balances can go wrong. Some chemicals might go up, some chemicals might come down. These imbalances can cause a psychiatric problem. In delusional disorder, some neurotransmitters, especially neurotransmitters like dopamine, increases in the brain. That can cause psychotic symptoms. So delusional disorder, biological or bodily reason is changes in the neurotransmitters levels can cause delusions. And there are also studies indicating that it could be inherited. When I say inherited, don't be alarmed that when a father gets a disease or a disorder, a son or a daughter should get it. No, it doesn't work that way. What is inherited is a propensity, the ability or propensity to develop the illness, but that may not happen. Person might go without the delusions lifelong. So it is only a propensity to develop a particular disorder is inherited. Its expression depends on many other factors. And the second group of causes is psychological. So it is a psychological makeup and how we develop from our childhood to present day, what we went through, what we learned, what we experienced, what our emotions, everything together forms our psychology. And when something goes wrong there, then the person can develop delusional disorder. What we call it as psychological vulnerability, low self-esteem, repeated stress can lead to psychiatric disorder. It can also lead to delusional disorder. And societal or social cause, stress and social isolation. Immigration could be one of the reasons where a person immigrating from one culture, one country to another new country, new culture can get isolated. That can itself cause stress and that can lead to psychological problem, including delusional disorder, which is not very common. And another important factor is alcohol and drug use. Alcohol is one of the important reasons for persons developing delusion, paranoid delusions. We can see many of our patients, alcohol dependent, very severe alcohol dependent patients, we can see a lot of delusional material in them, a lot of delusional beliefs in them. So these are some of the causes of delusional disorder. Okay, doctor, you say that it goes unnoticed and it is not going to disturb others, and do we have to treat them? And if we leave them untreated, what are the complications? So next is complications of delusional disorder. Now, secondary to delusion, they can also develop depression. Now, or anxiety. I remember a patient who had a delusion. This is an alcohol patient. He was withdrawing. This I'm talking about 35 years ago. Because the incident is so impactful, so kind of a shocking. I'm able to remember that incident. Okay, so I am examining the patient, and he is alcohol dependent, and he also has a lot of delusions. The most predominant delusion is there are people trying to harm him. They are trying to kill him, and he feels that people are outside the ward, that people are waiting with knives and all lethal weapons to kind of kill him, murder him. And he was telling, I was there, and other team members were there, nurses, psychologists, everybody was there, and he said he was talking very intensely about delusion, and he asked that, can I have a break? I just need to go to the toilet and come back. We said, it's fine, okay, go and come back. He went to the toilet. Somehow he found some sharp object and tried to start slashing himself. Immediately we were intervened, no major incident happened, but that explains the delusion can lead to a lot of emotional disturbances, emotional distress. Now, because they believe in that particular belief, nobody else believes in that. Everybody says it is not real. For him it is real. Imagine, for us it is unshakable false belief, it is false, but for the patient it is real. So they go through all the emotional reaction for a person who goes through real incident like that. So they can have depression, anxiety, it can also push him to suicidal behavior. And the delusions by themselves can isolate them from others. Because they believe in persecution, they believe everybody is against them, and they will try to avoid people. There is something called pseudo-community, a very interesting concept, pseudo-community. I'll explain to you. There are two persons in my workplace talking, and suddenly I believe that they are talking about me. And then that develops into a systematized delusion. Now I have a system in that delusion. I'll say two people are talking about me, they are against me. They don't like me, and they are trying to harm me. They are talking about how to kill me, and wherever I go, they follow me. And I see these two persons, they are talking about something, very normal conversation, but I perceive it something wrong, something going wrong. That two person goes and talks to somebody else. Then I'll say, now it is three persons here. Those two persons were against me. We went and talked to them. Other person, say let's say A and B were talking. He goes and talks to C. and I'll say C is also against me now. Then the C comes and talks to my secretary. So for some reason, so he wanted an appointment for one of patient or anything, so he talks to the secretary. I'm watching that. Then I say, now they also convinced my secretary. Now they are also trying to turn my secretary against me. So what I am developing is a community of people against me. Because it is a false belief, it is a pseudo community. So that can happen. So I get isolated. So I might start kind of missing my work, missing my appointment. I'll stay away at home, fearing that something might happen to me. So these are all the complications. So all this can lead to self-harm, or it can also lead to aggression to others. Suppose I have a very strong belief they're going to come and hurt me, assault me now, then I might react to that. I might challenge them verbally. I might become verbally aggressive. I can also become verbally, physically aggressive. And delusion of jealousy, the delusion about my wife or my husband or my partner is not faithful to me, and delusion of infidelity can lead to marital disharmony, because the partner may not understand the person is suffering from a psychological disorder. For the partner, it will be very, very hurting when she is very faithful to the husband and husband blames her that you are not faithful to me. Now I think you are having relations with somebody else. It will be very, very painful. So they can also go through depression, anxiety, and everything. I mean, self-harm, all suicidal behavior, everything they can have experience, or it can lead to marital disharmony. And some of the delusion can also lead to problem at work. These are all some of the complications of delusional disorder. And course and prognosis, what happens to these people? How many of them get well? So let's look into that. As I said, for many years it might go unnoticed. So that means they are missing the early intervention. If I develop delusion today, somebody is able to spot it and take me to this treatment center and initiate a treatment, the response will be much, much better. That's why in the United Kingdom or in many of the countries, they have early intervention services, early intervention of psychosis services. So when you intervene much, much earlier, the treatment success is much better. Prognosis is good. So in delusional disorder, it goes unnoticed. Person might, friends and relatives, family might notice, but they may not challenge them. They may not go further to ask what is happening. So that can lead to chronicity. So it goes unnoticed, that is one course, and tends to run a chronic course. Now, delusional disorders sometimes can be very, very resistant to treatment. This can run a chronic course. Generally, if you look at the studies now, which tells us that about 50% of the delusional disorder patients respond well to treatment, and another 20% show partial response. Now, the intensity of delusion might come down. They may not act on the delusion. They may not go and challenge people. They may not go fight with people thinking that they are against them. All those behavior will come down. Emotional reactions will come down, but core delusion might stay with them. But it will not affect others. So that way, they might have a partial response, but they'll be able to cope with the life. And another major problem in treating these patients is because they lack insight, they don't believe that they have a problem, they have illness, it is very difficult to continue the treatment. We might convince them to take the treatment, family will support them, they might take treatment for a month and then they stop it. Because the delusions might come back, then they might think that I am not suffering from mental illness. What others say is wrong. I believe that's what is happening. Now that person is against me. You will go back to the delusion. So that is one of the problem of treating these people. So maintaining the treatment, continuing the treatment is a problem. So we need to continuously counsel them, review them and support the family to maintain the treatment continuity. Okay, then what is the treatment? So in psychiatric disorder, treatment can be divided into two: psychopharmacologic or medication, or we can say biological. Now there are a few other than medication, there are a few other intervention which uses the bodily intervention, like ECT and other things. But delusional disorder, predominantly it's a medication. So there's a group of medication called antipsychotic medication. There are a number of medications under them. So that medication can be prescribed for the person. And usually the psychiatrist or a mental health professional who assess a patient, they'll decide about a particular medication depending on the medication side effect profile. If the patient has already taken some medication, the effect of that medication, and how we're going to administer this medication, whether some of the side effects can be against their compliance. Suppose I'm going to give you a very sedative type of medication. There is a very good antipsychotic which also gives a good sleep. Suppose patient believes that the partner is not faithful, and when he sleeps, the partner goes away and has a relationship with somebody else. If that kind of person, I'm going to give that antipsychotic with a strong sedation, then the delusion might get reinforced. My wife is giving me a medication which knocks me out so that she can go out. So we need to decide what kind of medication we give, depending on the profile, depending on the patient's physical health also, because some of the medication can increase the weight or has a propensity to induce diabetes. So we need to be careful about the background and family history of diabetes, all those things. Depending on different parameters, we select a medication. So once the medication is selected, it's prescribed and the patients are followed up. And depending on the follow-up information, we may change the medication, increase the dose. So they need to continue the medication for a long period of time, because it is a major mental illness with the chances of relapse. Every time patient stops the medication, relapses, the patient goes in for a chronicity. So it's going to last longer. So that is very important. The patient need to be compliant with the medication. So that is about medication. Then there is another group of therapies called psychological therapies. There are a number of psychological therapies for a delusional disorder. What the research says is CBT and family focused therapies are much result producing than other therapies. So commonest therapy we use is CBT for psychosis. There are different disorders we can use CBT. There's one CBT called CBT for psychosis that can be used for delusional disorder. In addition to medication and psychological therapies, we can also give them some social supports. The last bit is about family and carers, because it is important that family and carers understand the problem. Understand that this is a psychological problem. They are not doing it wantedly. It is a disorder. It is the chemical changes in the brain which produces a symptom, and it needs treatment. Sometimes the relatives, the family can react differently. Family can say that he knows everything, he does it wantedly. So they might have a negative emotion towards them. So they need to understand it's a psychological problem and it needs treatment. Because unless family is also convinced that there is a need for treatment, they may not promote that treatment. So family needs to know it's psychological disorder and it needs treatment. And few things they can do now to avoid critical comments, to avoid emotional reaction. I know it's difficult in a situation where a person lives with another person with intense delusional thoughts and acting on those delusions. It is difficult, but as far as possible, try to avoid critical comments and do not challenge the patient. Now, because for them it is real, they believe 100%. Initially, you can tell them, if they don't kind of come on board with you, don't keep repeating that when they are acutely ill. So also avoid arguments about it. So what they need to do is take them to the treatment services, mental health services, so that the professional can deal with them. Professionals know how to talk to them, how to get the information, how to convince them to take medication. So they need to be aware it's psychological disorder and needs treatment, avoid critical comments and avoid negative emotional reaction, and do not challenge the patient, and avoid arguments, and also learn about the disorder. So there are a number of avenues you can learn. There are websites which talks about different psychological disorders. mind.com is one website which gives you good, reliable information. And of course, you can watch my episodes, different episodes. We have done over 32 episodes now. It will go on. It will go on for another 150 or 200 episodes. We keep doing this. Now, we have covered quite a bit of disorders now so far. And so these are all some of the take-home points now for the relatives or family and carers. So, dear viewers, in this episode, we learn something about delusional disorder. I explained to you about delusion. I informed you about different types of delusion and also what is it required for making a diagnosis of delusion. And I talked about prognosis, prevalence and prognosis. And I also talked about course, how it goes, and the complications and the treatment. Thank you for watching this episode. We will come back to you with another episode discussing about bipolar disorder, which is another very important psychotic disorder which we need to learn. So I will talk about it in the next episode. Thank you. See you soon. Bye.